I'm Dr. Raymond, and I'm here with two cardiac electrophysiologists, Dr. Mohammad Iqbal and Dr. Giky Karwiky from Hasan Sadikin General Hospital, Faculty of Medicine, Universitas Padjadjaran, Bandung, Indonesia, to discuss our study titled Very High Power Short Duration versus Conventional Ablation for Pulmonary Vein Isolation in Atrial Fibrillation, a systematic review and meta-analysis. This topic stems from the fact that despite the advances in AF ablation and improvement in PVI durability, the procedural duration of PVI remained considerably long, thus imposing constraints on the quantity of ablation that can be performed in a given day, and thereby leading to a lengthy waiting list. Meanwhile, waiting time and longer time to ablation from diagnosis were associated with increased morbidity and AF recurrence. One of the current approaches is very high power short duration ablation, which can significantly shorten the procedure time and possibly increase effectiveness. Although single shot systems offer short procedural duration, point by point ablation retains advantage that will be discussed shortly. However, the use of very high power ablation technique raises safety concerns. Thus, our systematic review and meta-analysis investigate very high-power, short-duration ablation versus conventional ablation for PVI in AF. The aim of this study was to compare the effectiveness and safety of very high-power, short-duration ablation with conventional ablation for pulmonary vein isolation in patients with AF. A total of 13 studies comprising of 1,527 patients were included in this analysis. AF recurrence occurred in 40% of the VHPSD group, and VHPSD was associated with lower AF recurrence with the OR of 0.65 compared with the conventional ablation group. Subgroup analysis showed that additional ablation beyond PVI had a similar rate of AF recurrence that is 16% versus 10% compared with PVI alone. Procedure and ablation durations were significantly shorter in the VHPSD group. Complications occurred in 6% of the VHPSD group, and the rates were similar between two groups. VHPSD ablation resulted in less AF recurrence and a shorter procedural time, according to our study. Dr. Iqbal, what is your thought on the rhythm control in atrial fibrillation?
Okay, thank you, Dr. Pranata. So if we take a look a bit at the history of the rhythm control, we already know that the previous large trials, such as AFRAM trial, already published almost 2 decades ago, as I remember is around 2002, showed that the outcome, the rhythm, and the rate control was same. But however, at that time, the rhythm was mainly using the anti-arrhythmic drug, especially amiodarone. But we have to be careful to make a conclusion that rate and rhythm control is same, because the AFRAM trial actually showed that the benefit of rhythm control, but the benefit of the rhythm control was offset by the side effect of the anti-arrhythmic drug, mainly with the amiodarone. Therefore, the net clinical benefit of the rhythm control was not too obvious at the time. And such a clinical trial, the current clinical trials such as STAR-AF, Cabana trial, also the Kestal-AF trial, supported the strong role of the catheter ablation or rhythm control is superior compared to the rate control, and also for the patient with heart failure. And moreover, is AFNet provide the benefit of the early rhythm control with anti-arrhythmic drug and catheter ablation also. We have to remember that AF begets AF, sinus begets sinus, AF begets heart failure. Therefore, I believe that the earlier rhythm control to maintain sinus rhythm is better. The earlier is better. While the evidence supporting ablation is getting stronger, and AF ablation, I think, is becoming more efficacious. But the procedural duration was considerably long for some operator, probably. thus imposing constraints on the quantity of ablation that can be performed within a given day. So probably if you have a lot of case of AF, leading to a lengthy waiting list. Moreover, we already know that the longer time of procedure also make higher complication. In some cases. Meanwhile, waiting time and longer time to ablation from diagnosis probably were associated with increased mobility and also AF recurrence. As I said before, AF begets AF, AF begets heart failure, and paroxysmal AF become persistent AF. That's my opinion.
Thank you, Dr. Iqbal, for the answer. We have come a long way with more evidence supporting rhythm control by catheter ablation. The indication for ablation is ever expanding, and it should be met with increased efficiency with shorter procedure without compromising efficacy. This brings us to the next question. What is your thought on the future of radiofrequency ablation, and how does it fare compared to other methods such as pulse field ablation or cryoballoon ablation, Dr. Iqbal?
Okay, Dr. Pranata, thank you. So we already know that some current approach and also the traditional approach of the area ablation. The traditional approach I call low power, long durations. We can use 30 to 40 watts for about 20 to 40 seconds. And then the new one is high power, short duration. We can increase the power up to 50 watts. Probably we ablate for about 10 seconds. And the latest one, very high power, short duration. Even we can increase the power to the 90 watts for about 4 seconds. So we will discuss the very high power short duration. The catheter is novel contact force optimized for temperature control ablation with microelectrode and 6 thermocouple for real-time temperature monitoring during ablation. So the associated very high power short duration algorithm module to maintain target temperature during lesion formation. For maximum, let's say temperature is 65 degrees Celsius by using 90 watt for about 4 seconds. Theoretically, and also supported by some evidence, by increasing the power output in a very high power short duration ablation, is it possible to reduce the duration of ablation per lesion? Maybe probably about 4 or maximal 7 seconds, along with the potential creation of shallower but wider lesion, because it can facilitating complete isolation while also reducing the procedure time. And the efficacy of the very high power was comparable or even superior compared with long power, long duration, the traditional ablation, as mentioned with our paper, and standard high power short duration also. A shorter ablation time equates to more procedure that can be done within a given time frame. So you also asked about the current approach or other approach like cryoablation and also pulse field ablation and radiofrequency balloon catheter ablation. Of course, this technique might provide single shot ablation. We know that. However, it also have a limitation. This system may need traditional RF ablation, still need traditional RF ablation if the lesion and circumference is not adequate. So additionally, cases of complex anatomy, which the anatomy cannot fit to the cryoballoon, such as huge common unshroom of pulmonary vein, and also uncommon angulation of some vein, and especially of the right inferior vein, it may also have a miserable effect on the efficacy balloon system. But I believe that in the future, with some uh, advance the catheter design, I think the anatomical issue become less with this technique. But I also believe that till that ablation is a point-by-point ablation via a single tip catheter, usually combined with three-dimensional 3D mapping system, is still the most common energy source is radiofrequency. I think it's still the gold standard for the IF ablation, in my opinion.
Thank you, Dr. Iqbal, for the answer. So radiofrequency ablation retains advantage that it does not need to revert or to convert to other methods of ablation using different catheter. If, for instance, the lesion encirclement is not adequate, or we opted for additional ablation, or there is anatomical issues. Let's move on to the next question regarding the lesion formation. Dr. Giky, what is your thought on the lesion biophysics in VHPSD, and how can we optimize our ablation?
As mentioned by Dr. Iqbal, that ablation in high power for short duration result in increased resistive heating, but reduced in conductive heating. So reduce the potential damage to the surrounding structures. And in the case of very high power short duration, if we compare the lesion compared with the conventional ablation, the very high power and short lesion creates a more shallower and a wider lesion compared with the conventional. So resulting in the better encirclement and 100% lesion contiguity compared with only 25% in the cases of low power and low division ablation, the conventional type. So in animal study demonstrated that in very high power short duration have a reduction in gaps from macroscopic gaps or microscopic gaps. Also, if we evaluate the scar formation, lesion formation during follow-up, and we use the MRI, shows that the very high power and short duration have a lesion so more durable and more have a translation with homogeneous and contiguous scar formation during follow-up. So this very high power and short duration have advantages involving in the atrial tissue that also have a characteristic of thin tissue in the case of atrial fibrillation. Because maybe in these cases of the atrial fibrillation have match characteristic with more shallow and more wide lesions. And also we must note that have several important variables that impact lesion size and transmurality during application of RF energy. Several variables that impact the RF energy include the catheter stability, the contact force, the power output, the temperature, and the duration of the RF energy application. In particular, the catheter contact stability is an important factor contributing the clinical success. A contact force of 8 grams and a maximum temperature of 47 degrees Celsius are optimal cut-off value for the adequate lesion formation. In the very high power short duration ablation, as mentioned by Dr. Iqbal, that very high power using 90 watt RF energy and application time just 4 seconds are fixed during the ablation. So the maximum temperature result is the only modifiable factor is the contact force. So ensuring the adequate contact force is very important in the case of very high power and short duration.
Thank you, Dr. Giky, for the answer. So to recap, VHPSD ablation creates a shallower and wider lesion compared with conventional ablation, thus resulting in better encirclement and lesion contiguity. To optimize ablation using VHPSD, we must maintain a contact force of at least 8 grams. This is important and we should make sure of it to improve our efficiency and efficacy, which it brings us to the next question on technical aspect of ablation. From your point of view, Dr. Iqbal, what are the technical challenges in performing very high power, short duration ablation?
Thank you, Dr. Pranata. So I think the technical challenge issue is similar with the traditional ablation, low power, long duration. As I remember that very high power subduration, especially Q, that for the first time was introduced go back about 3 to 4 years ago with the contact force and temperature control. So the duration and stability of the catheter contact play crucial role in the effective delivery of the radio frequency energy. It's also including low power long duration. So using very high power short duration, is it possible to decrease the required contact time? However, the presence of the catheter instability can be a limitation in very high power short duration ablation, in my opinion. Because this is due to relatively short contact time, just only 4 seconds, which means that any movement of the catheter during this period can have a more pronounced impact on the quality of the lesion as opposed to low power, long duration ablation. Although one may argue that very high power may create adequate lesion within short time frame, and probably contact force will limit this issue. But in instance, when the operator encounters such difficulties, maybe the operator may switch to the conventional method, to the low power, long duration, in my opinion.
Thank you, Dr. Iqbal. To recap, although unlikely, catheter stability may become an issue during VHPSD ablation. However, we can always refer to lower energy setting with longer duration if needed.
Okay, Dr. Pranata, I think we shall discuss one of the most important aspect, the safety of very high power ablation. To be sure that very high power ablation can reduce the procedural time, but we have to take a look carefully about the safety of this approach. So, Dr. Raymond, what is your opinion on the safety profile of the very high power short duration?
Thank you, Dr. Iqbal, for the question. In terms of safety, it is noteworthy that VHPSD exhibits a relatively low incidence of adverse events, primarily attributed to vascular access complications, which are not directly linked to the use of the high power setting. The incidence of serious adverse events related to catheters, according to our study, such as avulsion and cardiac tamponade, was only reported in 6 out of 349 patients, that is 1.7%, and 3 out of 873 patients, that is 0.3%, respectively. So it's a relatively rare complication. There was no significant difference in terms of cardiac perforation, pericardial effusion, and tamponade in VHPSD compared with the conventional ablation using the meta-analysis technique. The utilization of VHPSD ablation can be particularly advantageous in cases involving thin atrial tissues because it facilitates the creation of shallow and wide lesions. Therefore, our result challenged the concerns that higher power delivery is related to a higher risk of tamponade. The studies did not report esophageal lesion necessitating intervention. However, caution should be exercised to avoid overlapping of VHPSD lesion, particularly in thin areas near the esophagus, and coagulation formation on the catheter tip is not uncommon. Nonetheless, it did not result in a clinically apparent adverse event. So, although there is a significant proportion of individuals who undergo VHPSD ablation experience silent cerebral events due to the absence of pre-procedural cerebral MRI as a comparator, there is uncertainty regarding the extent of the importance of such procedure-related silent cerebral events in patients with AF who are already susceptible to such events. So the majority of silent cerebral lesions are asymptomatic and resolve on their own. So we should optimize our procedure by effective management of sheaths, minimizing left atrial dwell time, continuing anticoagulant, maintaining a target ACT above 300, and delaying post-ablation cardioversion for 4 weeks. This may reduce neurological adverse events. In the long term, the benefit of sinus rhythm restoration in terms of cerebrovascular events outweigh the risk of catheter ablation. And in terms of these silent cerebral events, it is also not it is also unclear whether it is due to the procedure or only caused by AF in the background in preceding years.
So, Dr. Pranata, you already mentioned, as we also mentioned in our paper, the most important thing that the concern of the higher rate of the complication in very high power have been dispelled by this study that show is low incidence of serious complication. With similar safety profile with the conventional ablation, low power, long duration. So this is especially important because the safety concern might prevent its adoption in clinical practice and clinical evidence affirm its safety. So I think our paper showed that the very high power short duration is very safe.
Thank you, Dr. Iqbal. Then one of the most important practical points is when we should revert to conventional ablation. Dr. Giky, what is your opinion on reverting to conventional ablation when VHPSD ablation is not feasible, and when should we do it?
Thank you, Dr. Pranata. As we discussed before, because of very high power short duration ablation result in a wide but more shallow lesion, that in the cases of tissue that were thicker, so we must have a combined approach. Ablation may be necessary to achieve the optimal result. So touch up with the standard power titration mode with temperature control ablation with the power limit of 50 watts can allow to achieve maximal pulmonary vein isolation if deemed necessary for such cases that have a thicker tissue. So if we do the ablation that have a pulmonary vein reconnection during a short-term period of observation, maybe we must consider for the conventional ablation as touch-up for the very high power short duration. So this suggests that the very close protocol can reduce the necessity of conventional ablation. And when the PVI is not achieved, the pulmonary vein isolation is not achieved, and also if there is an acute pulmonary vein reconnection, so again the conventional ablation may be necessary. So also, as mentioned before by Dr. Iqbal, that if we cannot have an adequate contact also cannot be achieved during the very high power short duration, we can refer to the conventional ablation. Thank you.
Thank you, Dr. Giky. So we can always refer to the conventional ablation if PVI is not achieved or there is acute pulmonary vein reconnection. We can always refer to for additional touch to the using conventional ablation. And we can also use a very close protocol described by one of the study we have included. They say that we can achieve fast and safe PVI without the need for reverting to conventional ablation. However, we can always refer to conventional ablation if we deem that necessary. Moving forward to the highly debated topic, Dr. Iqbal, a routine additional ablation may not be beneficial. However, can we personalize it based on the patient's characteristic?
Okay, thank you, Dr. Pranata. This is always a very interesting question. So many pro and contra, because several studies show that addition of posterior wall isolation, linear ablation, cafe ablation do not reduce recurrence of AF in some studies. The same applies for prophylactic CTI ablation during PVI in AF patient without typical atrial flutter. So this meta-analysis support the finding of this study, and that routine additional ablation might not be necessary. Previous meta-analysis also shown that irrespective of the presence of the typical atrial flutter, additional CTI ablation is not associated with improvement in recurrence of the all atrial arrhythmias compared with PVI alone. But however, the author of this study, additional ablation, may be considered in individual cases, not in routine case, of course, with presence of the typical atrial flutter and in patient with recurrent AF after the initial stand-alone PVI procedure, or in patient who do not achieve restoration of stable sinus rhythm despite a successful recurrent PVI. That's my opinion. But our paper shows that probably additional ablation in very high power is not beneficial.
Thank you, Dr. Iqbal, for the explanation. So routine additional ablation may not be necessary. However, it can be individualized, not routinely used. We may consider additional ablation in the presence of typical atrial flutter or in patients with redo procedures. So from the study, the first point is VHPSD catheter ablation is associated with lower AF recurrence and shorter procedure time than conventional ablation. The second point, routine additional ablation beyond PVI in VHPSD may not provide additional benefits compared with PVI alone. Additional ablation may be considered in individual cases, such as with the presence of typical atrial flutter, or in patients with recurrent AF after initial stand-alone PVI procedure, or in patients who do not achieve restoration of stable sinus rhythm despite successful recurrent PVI. And the third point, cardiac complications were rare in both VHPSD and conventional ablation group and consisted mostly of vascular access complications. Thus, the use of VHPSD catheter ablation can improve efficiency and outcome without compromising safety endpoints.
Very high power short duration can be recommended in our clinical practice.
Yeah, we also have a safety profile compared with the conventional ablation. Thank you.
That's all for the podcast for this study. We hope it can help us in the routine clinical practice.